Well, thank you very much, and I'm delighted to be here. What I'm going to do is, as Phil explained, talk a little bit about the development and the background to the intervention, which we have now developed and implemented to a certain extent in Ireland, and which Sonia will tell you about. How did this all start? Well, partly because, you know, the interest in terms of, well, my interest and the interest that came from my work about the concept of dignity and its relation to nursing and palliative nursing in particular. This intervention is particularly a nursing intervention. You know, we have numerous interventions in palliative care, but very few speak to the profession of nursing in particular. But this intervention absolutely was designed to do that, and as you know, to community nurses in particular. So some of the background was around that we know that actually, if you think about palliative care and end-of-life care as a worldwide phenomenon, that people fear loss of dignity more than they fear anything else. That's quite apparent from the evidence base to date. But also that palliative care is helping people die with dignity. The difficulty with that term, of course, is that some countries in the world would perceive that as euthanasia or assisted suicide, and this is absolutely not what we're talking about here. It's really interesting when you're doing a review or looking at the concept of dignity, how that word has been taken over by the sort of euthanasia or assisted suicide lobby in different parts of the world. But also around patient-centred, dignity-conserving care is to help make the patient's care much more individualised and person-centred. And again, that's part of what this work is all about. So I'm just going to talk a little bit about the DCI in terms of the past, the present, and what we're hoping to do in the future. So, I mean, the sort of idea for it came from my postdoctoral work in particular. And for my postdoctoral work, I did a project around looking at the concept of self-care in advanced cancer from the patient's viewpoint. So it was an in-depth qualitative study. The sort of innovativeness about it was particularly around using serial triangulated interviews, but also the work involved a participative, collaborative approach with patients. And it was when I was returning, it was a 2-year funded postdoctoral study, and it was from 2006 to 2008. And it was when I was going back to patients who were my collaborators in the research. So these were people who were at the end of life, so they were people who were being cared for in hospices, and it was they who said to me, do you know, Bridget, what I can see in your findings is dignity. And I hadn't really thought about it till now, and I certainly hadn't thought about it in the concept of self-care. But my own PhD, which is a long time ago now, I was just thinking about that just as I was sitting down there. So it's 14 years now since I was awarded my PhD, but I looked at the concept of the expert palliative care nurse. So even though many people would argue probably the data is a bit old, but some of the data still speaks to us today. I'm not expecting you to see the whole of that diagram, but I want us to think about some of the characteristics that I came up with, and this is from the patient's and nurse's viewpoint, with some of the characteristics of what we called what was determined as the expert palliative care nurse. And it involved in particular good communication skills. So that was actually every single patient who I interviewed in my study, and I interviewed 44 people who were coming to the end of their lives, and 44 nurses, all in-depth qualitative interviews, and they all said to me that good communication skills were really, really important. And in particular, they said patients would talk about the need for the nurse to listen to them. They used the term willing to listen, but also they talked about the relationship that the nurse has with the patient. This was really, really important to the patients. About knowing me as a person was a concept that they talked about building rapport, for the patient having confidence in the nurse, that the nurse spending time with them. And time doesn't have to mean loads of time as in clock time. Sometimes it's the quality time that the nurse spends with the patient. We might come back to some of those, but one of the things that I came up with, and I didn't actually ever take further because you go on to do other things postdoc, but it was one thing that sort of stuck with me, is this thing that the patients what I've called here is personal, and actually in my PhD I called it personal or humane characteristics. These were so important to patients, and you can see some of the ones that are listed there about being warm, compassionate, having a sense of humour, friendly, genuine, dependable, realistic, kind and dedicated, and I'm going to come back to those as we talk about the DCI. But it was when I was looking post my postdoc about the concept of dignity that I came across Harvey Chochinow's work. Harvey's a psychiatrist by background. He's called a distinguished professor of palliative care. Now he's winning, he says he must be coming to the end of his career because he keeps winning loads of awards. He was just awarded last week with similar in Britain to a Queen's Medal, but in Canada they call it Order of, I can't even remember what they call it now, Order of Canada, I think. Anyway, he's got his Order of Canada now. So he's distinguished professor, done a variety of work around palliative care, but particularly known for his work around dignity. And this is the model that he developed from an empirical, qualitative piece of work that he conducted both in Canada, in Winnipeg, Canada, which is where he lives and works, and in Perth, Australia. So it was a good piece of empirical work published in Social Science and Medicine. And they came up with this model, which has now been tested in a variety of ways. And when I was reading this model, I thought, you know, that's actually fits really well with nursing as well. The three main areas are illness-related concerns, dignity-conserving repertoire, and social dignity inventory. So these are terms that Harvey came up with. So the illness-related concerns is fairly self-explanatory, but the dignity-conserving repertoire says some things that probably those people working in palliative care absolutely can see how these are so important to people when they're coming towards the end of their lives. And I'm just going to pick up on a couple of the ones. Maintaining what the North Americans called maintaining normalcy, what I would call maintaining normality. That has very much come out of my own work, my own research, particularly my research from the patient experience point of view, both in terms of the self-care research and other research that I've done with people. In my self-care study, I followed 20 patients, did 71 interviews in total, 2 interviews with each patient. I asked them who in their friends or family had given them the most support at that time of the illness when I saw them. They were all in the last year of life, as far as that was possible to determine. And I also asked them what health professional had given them the most support. And every single patient, and they were only 20, but they were quite a variety of people ranging from 30 to 95, different, they all had advanced cancer, but different cancers, different social circumstances, but every single one of them, even when they were imminently dying, talked to me about maintaining normality. So that spoke to me when I was reading this model, but also this issue, which Harvey's called social dignity inventory. And it's particularly this one in the middle, which Harvey has called care tenor. So quite a North American term as well, literally means the tone of care, how the health professional approaches the patient. And that spoke to me in terms of my own work around personal characteristics. And it fitted so well to me in terms of that it's not just what you say when you're talking to patients, it's how you are. And how important that is, and it does require skill, there's no doubt, and we'll see that from the Irish results. But it's the manner of the person, more, some people might say attitude, but it's more the approach of the person, as in the nurse, to the patient. And when Harvey designed his model, he always thought that it would fit both in terms of clinical care, so people would apply that model in their own clinical practice, but also that people would develop dignity-specific interventions. And DCI is one such dignity-specific intervention. I'm the only person, lots of people have used Harvey's work around the world. He talks all around the world. Lots of people know his work, but I'm the only person who's designed a dignity-specific intervention for nursing. I think a lot of people think of his work as applicable to what the Americans called psychosocial workers. So people working in that arena. Well, I think, well, you know, don't nurses do psychosocial work? You know, and a lot of it has been applied to that sort of arena of practice. But I was very surprised, actually, that more people hadn't thought about it in terms of nursing interventions. So what is the DCI? It is, as many people will know, 4 really main areas. It's not just the whole intervention is all 4 of these things. So manual, I don't know about you, but how many people really use manuals now? I mean, you know, if you get a new phone or a new gadget, you don't tend to read the manual, you play with it. But we did think it was worth designing some sort of manual that people could go to when they wanted to. And that's something we need to think about for the future, making that electronic and easily accessible to people. But it is always preceded by some sort of training or education. And that was absolutely part of the Irish model. The first phase of the DCI uses a tool that was already developed by Harvey from his model, which is called the PDI, Patient Dignity Inventory, and we use it in our intervention for the nurse to assess the patient's key concern from the patient's viewpoint. But we designed from scratch. Sounds funny, doesn't it? Design from scratch, sounds like I'm cooking. Reflective questions and evidence-based care actions. And I'll talk a little bit about how we develop those, because I think it's important in terms of understanding the intervention as a whole. Any academic would say that any intervention should follow some sort of framework, and we chose the Medical Research Council from the United Kingdom's framework for evaluating complex health interventions. It's probably, although it's a UK framework, it is used in other parts of the world and is used widely as a role model for how you develop an intervention. That the first iteration of the MRC framework was linear, and then they re-evaluated it a few years ago now. This publication is 2008, to make it circular in response to feedback from people. And you can see that it has these different phases, that every intervention should involve feasibility or piloting, and that's really clear. I mean, people won't get decent funding for interventions if they haven't undergone some sort of feasibility and piloting phase. And I actually feel strongly that people should publish that. I do publish my feasibility phase. I think it's important for people to see what a feasibility phase involves. Then it is about evaluation, and you can see the key areas: implementation, development, but seeing it always as a circle. But when we were developing the DCI, it wasn't just the MRC framework that we looked to. We looked to this piece of work from Jo Rycroft Malone, who is a nurse, works in Bangor in North Wales at the moment. Jo Rycroft Malone has written widely about evidence-based practice in nursing, and is really a founder of this new methodology called implementation science, which I find really exciting. Well, you know, I'm an academic, but it's very relevant for nursing. And this is how I've adapted Jo Rycroft Malone, what she says in her paper on evidence-based practice. But basically she says that evidence in nursing is different. Evidence-based practice in nursing is different to other areas. And that we draw on different types of knowledge. And I think that's really, really important when we're thinking about how we implement interventions, but also how we test them. And for our DCI, we drew on all 4 bits of this knowledge. So that's about clinical knowledge, and that's clinical knowledge of nurses, as well as knowledge from patients, about the research, their empirical knowledge. So good evidence-based research. Local context, absolutely key, that we think about the local context in which we're implementing an intervention, but also looking to evidence-based guidelines. So we drew on all 4 of those when we were devising our evidence-based care actions that the nurse would use in the DCI. And we did that in a variety of ways. So the clinical knowledge, we did focus groups with nurses, so with community nurses, with GPs, with patients, with family members, and with patient families to know that we did 6 times 6, so 6 focus groups with a minimum of 6 people in each focus group, when we were doing this first piece of work in the northwest of Scotland. Which included the surrounding islands. It was really good fun. It's a beautiful bit of the northwest of Scotland when we did that original piece of research. We did a full systematic narrative review of the literature, which we have updated for the Irish project, which we published earlier this year. We looked at the local context. We looked at how nurses worked in that area, and we drew on what were local, and there are now national Scottish palliative care guidelines, but at the time the different health boards all had slightly different evidence-based guidelines. So we had a pile, literally a pile of evidence-based guidelines for different aspects of palliative care which we looked at. Okay, so this actually is a little bit faded, but this is how the DCI works, that the nurse assesses the patient using the PDI to assess the patient's key concern from their viewpoint. They identify then the sources of concern for the patient from that PDI. They use the reflective questions to address that issue further, and then they identify the appropriate evidence-based care action from the DCI. And then they use the care action which they've agreed with in partnership with the patient. They seek help or refer if needed, and they evaluate whether their intervention has worked using the PDI again. The first couple of, just to acknowledge some of the people who worked with me, particularly in those early studies where we were developing. Key person was actually Ulrika Östlund, who I was just been in Sweden week before last. Ulrika's back in Sweden. Ulrika got a postdoc, 2 postdocs from 2 different Swedish funders to come and work with me. She worked with me for full time for a year when I was at the University of Stirling in Scotland, and then carried on working with me for sort of part-time for a year, and was instrumental in helping the early development of the DCI. And we learnt to develop a little language called Swinglish, which we spoke again. I couldn't speak any Swedish actually, but I had sort of understood when she did some really weird spelling sometimes what she was talking about, and sometimes we have these weird words and between us, and sometimes I still notice them in publications. And they published that really weird Swinglish word. So just some of the other people who work with me. Actually, one of the things that we've identified even in the DCI is that sometimes nurses find it difficult to talk to patients about difficult issues, but also it's really difficult sometimes recruiting busy people. What I did in this study, I've actually just got a paper published in an American journal about reflecting on recruitment in palliative care research, and I chose in both the early Scottish studies to have nurses seconded to work with me. So both Katrina and Hilary were clinical nurses, they weren't academics at all. They really, neither of them even had master's degrees, but they were really good, experienced palliative care nurses. Hilary is a community Macmillan nurse. Katrina was a Marie Curie nurse manager, if you know what that is. But they came and they were brilliant at recruiting. Didn't help me so much in the writing of the papers, but they were absolutely brilliant at helping recruit, because the nurses knew them, and they knew them as a valued colleague in the area. So just to sort of cover, and Harvey's actually been a mentor to me throughout these studies, so I couldn't really have done it without him as well. So just to move on. So I'm just going to swiftly move on so that we get to the findings of the DCI, which you're waiting to hear about. So some of the things that we found in the first 2 studies. So the first study, we developed the DCI and we tested it from the nurse point of view in that first study, and then we went on in another area of Scotland, in the northeast of Scotland, in 3 different areas to test the DCI from the patient and family member viewpoint, and we tested it qualitatively. And some of the things that we found, that it was feasible to use to conserve dignity in dying patients. The patients actually really liked it. So the patients that were able to participate and that were recruited into the study really liked participating, and they liked the DCI in terms of helping them to help them communicate with the nurse, interestingly. And the nurses really helped us. The nurses in particular, more than the patients, helped us develop what the DCI looks like now. So some of the things we also found, that it did recognise and record the importance of the community nurse. Actually, when people talk about primary palliative care, and particularly in the UK and in recent publications, actually even in the APC publications, they talk about the general practitioner, and rarely talk about the importance of the community nurse. And in actual fact, if somebody's dying at home, who's doing the bulk of the care? Actually, it's the nurse. It's not the doctor, the family practitioner, the general practitioner. actually some of the things that we found and that our care actions were saying is they were confirming the evidence base and validating some of those comfort care activities that sometimes get lost when people are really busy working to targets, etc., etc. That nurses were able to identify dignity-related concerns from the patient's viewpoint absolutely reinforces this importance of person-centred care. But we did also know that we needed to do a wider evaluation. I'm just going to move on. So what am I doing right now in terms of the DCI? I've got a sort of development grant at the moment, and this is about looking at ways that we can test the DCI on a wider scale in the future. And so what we're doing at the moment, we're doing a systematic review, and we're looking for patient-reported outcome measures which will help us evaluate the DCI when we do it on a wider scale. So far, in all our studies, we've mainly evaluated the DCI qualitatively in terms of doing interviews with nurses, patients, etc., and family members. So we're doing this systematic review at the moment, which is driving my team completely bonkers because we've got far too many papers at the moment. They're doing the whittling now, so I keep hassling them. Well, where are you down to? So we're working with the University of York, who are known for their expertise on evidence synthesis. I can't even say that now. Evidence synthesis and systematic reviews. So they did the searches for us. So they're experts, identified far too many papers. But anyway, that's just the way it happens at the moment. So we're whittling those down at the moment. And we're going to test them against the gold standard patient-reported outcome measures, which we know from the excellent work that's happened, European-funded work, that Irene Higginson's team have led on the More Care project, excellent project, has said what are the key measures, the key aspects of measures in palliative care. So we're going to test against those when we come to the end of that study, which we're 6 months into a 12-month project. We're going to look at the educational component, we're going to look at what's happened with the DCI in Ireland and think about, will that work when we do the DCI on a bigger scale? But we're also going to talk to community nurses to look at the barriers and facilitators to help busy community nurses when they're implementing interventions into practice, so we can think, can we do something to help them when we're implementing interventions like this, to help them improve their end-of-life care. So just what the DCI is looking like now, so those of you who haven't seen what the tool looks like. So this is the PDI. So the tool at the moment is nurse-centred because it's the nurse who uses the tool. There is an aspect which of course the whole tool is patient-centred. There's an aspect that the patient can have, but the tool is designed, this bit of the tool is designed to help the nurse. So this is what the nurse uses to assess the patient's key concern and the patient's viewpoint. So Harvey had 25 items in our PDI. We added 26 because that's in the tool. It's really funny that so many, particularly the North Americans who think they're so good at talking, are afraid to say we're worried about our illness and death. But actually the patients like having that in there. So the nurse rates that on a scale of 1 to 5, and we say for our DCI, this is different to how the PDI is used around the world, that anything that's 3 or above is a concern and the nurse has to take it further. So that's the middle column in terms of reflective questions, and then this is some examples of what the suggested care actions look like. And as I say, we've updated those recently from the systematic review that we did as a team for the Irish project. So just where we're going further, we hope to take this to a bigger project across Europe. At the moment we have 3 definite countries in the UK, Ireland and Sweden. Swedish have already now translated the DCI, and they're just doing cognitive interviews to test that into the Swedish context. But we hope to start that to do the European study next year. We're almost ready to start to look for money for that. So that's where we are with that at the moment. And then I'll just leave so Sonia can talk, but you can ask me some questions in the question bit afterwards.
Thank you.